Can we start?
Yes, I think it's 8 o'clock. We should start. Other participants can join us as and when they come. Okay, let's begin. Dr. Winston, you're okay? Can we start?
I'm ready to go anytime. Yeah, here we go. Let me just
Yeah.
share my slides and we keep going.
All right. So, welcome today to another talk. Today's topic is a very interesting topic. It's on spasticity management, and generally, as physiatrists, we manage spasticity by a combination of drugs, exercise, and chemical neurolysis, either with botulinum toxin or with phenol. Today, we are going to learn about a new and a novel treatment for spasticity management, and I'm very interested in knowing about this topic further. I will ask our secretary, Dr. Nitesh Gonade, to introduce our speaker and take it forward from there.
Hi, Paul. Today we have basically very renowned clinical professor who is working currently at the University of British Columbia, an island of medical program. He is a past president of Canadian Association of Physical Medicine Rehabilitation, and he is one of the co-founder member of Canadian Advances in the Neuroorthopedics for Consortium.
Sorry, just your voice cut out for me.
Nitesh, you're muted.
Sorry. Hello, am I audible?
Okay, should I start? I just because
Yes,
your voice cut out
yes.
at the end. Okay, perfect,
Am I
great.
audible?
Okay, well, thanks.
Okay, yeah. Good
Really
evening, Paul.
honor to.
Today we have the very renowned speaker who is a clinical professor at University of British Columbia, an island medical program. He is a past president of Canadian Association of Physical Medicine Rehabilitation, and one of the co-founder of Canadian Advances in the Neuroorthopedics for Consortium. I met with Dr. Paul in ISPRM Sydney in a workshop of CRYONEUROLYSIS, which was very worthwhile and new for me, even the new for the most of the PMR specialists in the India also. That's why I thought this topic is really very worthwhile to learn the new techniques for spasticity management. Okay, now I can hand over this mic to the Professor Paul to start the presentation.
Okay, well, thanks so much. It's a real honor to speak to all of you. It's the first thing in the morning here on the west coast of Canada on the Pacific Ocean. So hello from the other side of the world. Thanks so much. I really love teaching these international workshops. And I think speaking to your group is a little bit easier because you have more experience using phenol, which is sort of a lost art in a lot of, like in my country, very few people use phenol because botulinum toxin is covered by the state. So that is lost. So I think you'll have an advanced practice agenda here. And most of you are probably interventionalists in pain. So you will be much more comfortable than the average physiatrist who doesn't have the same experience. So we're going to talk about a complete paradigm shift. How do we take a pain treatment that's been around since the 1960s and adapt it to spasticity? So I really need to point out my colleague, Dr. Daniel Vincent, who is an anesthesiologist. He helped design this program with me. He's just come back out of retirement, but he has been doing cryoanalgesia for pain for about the last 25 years. And working together, it was his idea that we try cryo for spasticity. So my objective today is to understand that when we tell people they have a contracture of their limb, we're often wrong. And we don't know they have a contracture until we do an anesthetic lidocaine block. So what often seems like a contracture can actually open up. It's just too much spasticity. It may not respond to botulinum toxin. And if you've done phenol, you will see that you can get greater increase in range of motion. We're going to understand how to do cryoneurolysis to select your patients, and we're going to look at the clinical outcomes. Now, everything we do is very open. We share all of our ideas, and we have a training clinic. So you can see a group that came up from Harvard recently. We have a big group from Mayo and Yale. We have doctors from all over the world every month coming to train with us. And this is my team. It's all funded by research. I don't get any support from my hospital yet. I have to raise money in order to hire my team through my hospital. And these are all the people that have come from around the world, and many of them have started their own cryoneurolysis clinics. I'm just going to pause here and you can take a screenshot. This is the textbook that we created during the pandemic. It's the ultrasound guided nerve targeted procedures. And it's with spasticity experts from around the world. So surgeons, there's chapters on phenol, nerve blocks, surgery, neurectomy. And this textbook has 65 videos that you can scan the QR code and watch. So it teaches you how to do these diagnostic blocks for almost every muscle to decide what treatment. Now, I will point out that we have become more and more advanced since we published the book a year ago, but by doing the book, we have a lot more intramuscular targets, and those are in the videos. So what are we talking about? We're talking about patients that were refractory to treatment. So this woman had a spinal cord injury 36 years ago, had a stroke when they put on her halo. And, she doesn't have very much function in that hand, yet just at the end of treatment, she's able to open her hand and shake for the first time. So those are the types of changes what patients were told you've had maximum gain and further gain as possible. So what is a refractory patient? So this is a woman from Texas who comes up to visit me. She had a brain injury 12 years before, traumatic brain injury, large bleed, was in a coma for weeks. She is in a big center in Dallas, so she has a back. She had lots and lots of botulinum toxin. She had ankle surgery, and she even fractured her symphysis pubis because she had instead. So she's been getting proper therapy, proper treatment in the upper extremity with botulinum toxin, but it's just stiff. She can use her hand. She's very limited in function. There's a lot of dystonia. So she can do one punch. That's all she can do, and she tightens. And you can see her biceps muscle bulging out. Her wrists are tight, and she really didn't want me to touch her fingers, but you can see the thumb really curls under with a dystonic movement. So the first treatment we did was at the very beginning of our treatment studies. So we did her pec major and minor. So we are going to loosen those muscles through lateral and medial pectoral nerve. We'll also do the biceps, brachialis, and her wrist flexors. Now she's gaining a lot of range of motion, but still, because of her stroke and co-contracture, she can't get her arm overhead, but my fellow can do it. So we are relaxing the muscles, so she's getting a huge gain range of motion. But the question is, so for some patients, they're going to get a big increase in passive range of motion. Others are going to get active, depending on what their stroke or brain injury allowed them to have. So she's super happy with this. In fact, the first thing I said, well, you could only do one punch before. Why don't you take up boxing? So there's still that little bit of catch, but she said, it's crazy the improvements that I can do. So then we send her home and she starts boxing. So remember, only one punch before. So a lot of generation of force that she can do now. And then it lasts a long time. So she came back a year later and we added in a new muscle group, the axillary group, subscap, peries major, and latissimus. And I also did her FPL. And look at the difference in force by freeing up the axillary girdle. She is generating tons of force.
Okay, excuse the crazy hair, but I want y'all to see something that I haven't been able to do for 12 years.
So now she can reach her head. That was a big goal of her. For someone who has a lot more hair than me, I can understand why. So she can do this. She can now relax her thumbs. She's become very functional. She's able to lift weights, vacuum, house cleaning, do all of her, a lot more computer work. And the difference though is she's still tight. So there's still some stiffness in this muscle. So even her gains lasted a year. We added in more gains because it did not grow back. But she's really happy, but I'm actually not quite happy. There's still.
And now I don't have to do it again.
So I bring her back again. This would be about 9 months later because she lives in another country. And I realized it was really just the retraction of the tendon. Her pec was tight. And my colleague Nimish Mittal says in India, you way more physiatrists that do surgical procedures than we do in Canada. So this would be something that you might already do. So we just did a pectoral tendon release.
Oh my God. Okay, seriously. Did you see that?
Do it again.
So
Am I
we
the
got
only
rid
one
of
who's
all of
amazed
her
here?
spasticity.
So,
She
no,
still
I'm
had
happy.
tendon retraction. So now we've gotten
Not
rid of
Jeff.
spasticity, we've gotten rid of tendon
Well,
retraction.
Jeff,
She
look
still
at
just
this.
has a bit of
This is
dystonic
my
movement.
hand touching my right ear. Not, and you see the
And more
reach.
force generation.
I feel the reach. You did it yourself.
My
Right. And she went right from that pec tenotomy. So none of the procedures I do have any recovery time. Cryo is instant, and so is the tenotomy. So cryoneurolysis is not new. It's available in many countries, very limited actually in Canada before I started doing it. But it is a pain procedure used for years. So Andrew Trescott in Florida is the hero. So it's been used for knee procedures, for joint denervation for a long time. So one of the ways that I use it in hospital is to get people out of hospital faster. So this was a woman who had an acquired polymyopathy, sorry, neuropathy. She couldn't feel her feet. She was in hospital for a long time. She got COVID in hospital, was in intensive care unit, and after about 4 months in hospital on oxygen, she just couldn't walk. She was in so much pain from her knee arthritis. So we just treat her knee genicular, and she's able to walk and go home in a few days. So we know that it works for sensory nerves, but nobody thought about doing it for motor nerves. And this was the case report, and you can take some screenshots if you want to learn more. Every single one of our case reports has a video teaching you the technique. And I'm a physiatrist, so I'm not just interested in pain. So this was a man, unfortunately, is a homeless man where I live in Canada, which is quite sad. But severe pain, he can't walk, but also his knee is short. And we determined it was because his hamstring had contracted from his knee pain. So we just did an intramuscular hamstring
If it's too
cryoneurolysis
much, you can
into the
stop.
Yeah,
semimembranosus
Okay.
and semitendinosus, lengthened it, and his heel will go down. So that's how we're using cryo. Without the use of ultrasound and nerve blocks, the way people use botulinum toxin, it's just kind of, inject a patient, look into your crystal ball, and see. I think the patient will respond, come back in 6 weeks. The vast majority of clinics cannot accommodate follow-ups midway. So by the time you see them again, it may have worn off. With diagnostic nerve blocks, you really see what's going to happen. So we published this a few years ago. It's an open access, and it shows you the principles of how to do ultrasound-guided nerve blocks for almost any muscle. So what we do is we start often, we'll start at the upper extremity. So here we are in the biceps, about here. We know that the biceps innervation comes off the brachial artery. So we're going to track that little black ball sliding what looks like a fascial plane, but that's the musculocutaneous nerve. Now, I learned from my colleagues in France that do lots of diagnostic nerve blocks that we think people have contracture, but they call it a reducible deformity. So you can't relax it, but when they wake up in the morning, it might be relaxed. If they're really tired, it might open up. But if you do a lidocaine block, it opens. So this is a classic example of a woman who is in a supinated position. So that's an unusual tone for spasticity. Usually spasticity is pronated, meaning she's got a contraction of the biceps. But when we do the musculocutaneous biceps, it relaxes and opens up. So for almost every patient that comes in, we do selective motor blocks and sensory if needed. So this is an example of stimulating the pec major and the pec minor below. And we really found if you do not do the pec minor, you don't get a good result. So we stimulate both from the same area. We will then go on to do a lidocaine block. So the lateral pectoral nerve sits right underneath the pec major, and we're filling it up with lidocaine. You can see on the middle of the left side of your screen, the little blood vessel in that fascial plane telling us that's a neurovascular bundle. So our patients will have contracture. So this his complaint is shoulder pain. It's a non-functioning limb, but positioning is very painful, getting dressed is very painful, and he has a contracture of the pec muscles. But we do a suprascapular block for his pain, and then medial and lateral pectoral nerve, and it disappears. So then we know we can do cryoneurolysis. It is getting better by the minute as we're stretching out those muscles. So we were told he has a permanent contracture. We also did median nerve above the elbow because he has a lot of pain in that hand and it's stiff. It has been 3.5 years, and each time it's lasted about 18 to 19 months, and then I just repeat him. So this is exactly the procedure that Dr. Boissonneau is showing. So this is a patient with cerebral palsy. We are going to just lidocaine the skin just to numb it a little bit. And we are going to push a little catheter. Now we use a catheter because these muscles are very stiff and fibrotic, and our cryoprobe is quite bendy. So she's going to push in, and the target is that white line, which is the fascial plane between pec major and minor, and that holds the lateral pectoral nerve. We will do about 1 to 2 stimulations there for 106 seconds, and it's the freezing and thawing that will cause Wallerian destruction of that nerve. We will then dive down deeper into pec minor, where the nerve is not a straight line, it's an anastomosis. So we will look for a branch, stimulate it, freeze it, and if we don't get the whole pec stimulating, we know there's 2 fascicles, and we'll find another fascicle. So this is an example of an inpatient shortly after stroke, and you can see that contracture of his shoulder. It is retracted in. So for him, he doesn't have a lot of, we didn't need to do the suprascapular nerve, but we just do pec major and minor, and that contraction disappears. Here we are stimulating the pec minor. So we are going to relax it, and we get an immediate result. Now, Wallerian degeneration will continue, so I expect his range of motion to be much better in a few weeks, not just the immediate result. And so in effect, we're really comparing this to surgical neurectomy, which is a very bloody, difficult procedure to do in this area with lots of blood vessels. So as I mentioned, we don't know how much function people have under their severe spasticity. So this woman is 2 years post-stroke. She'd had lots of botulinum toxin by my colleague, who said, it's just not meeting her satisfaction. So we did cryoneurolysis to her pecs, biceps, brachialis, and in this case, I did her whole median nerve above the elbow, because when we did the block, we could see her fingers started to move. So she's got a wonderful response because she actually has an active movement. She's going to start using that. Many of our patients are too hemiplegic to actually use it, so she was a surprise. Now, I will tell you, she's had wonderful results. We also did her leg, and her leg got so good, I convinced her to get ankle surgery, which she did, and now she walks independently, walking her dogs. But at 18 months, the shoulders started tightening up again, and it was difficult for her to open her hand. So 2 weeks ago, I repeated everything, and like that, everything returned. So she can now feed herself. She can use her hand, she can do many tasks, and she was told she'd never use that arm again. So again, this is what it would look like if we did this surgically. The mechanism of action. So cryoneurolysis is a drug-free procedure. Many of you must be much more familiar with radiofrequency ablation. It's sort of the opposite. It's using cold. And all we are doing is putting a probe into a tissue, and gas will flow through that tube. It will go into the body, nothing enters the body, and then it drops to the boiling point of the gas, which is minus 88 degrees for nitrous oxide, or minus 60 for CO2, or like minus 140 for argon. And that will cause the water in the vessels to freeze. So it's your body that freezes. So when we put our probe in and target, say, the tibial nerve, we're going to be drawing the fluid out, but most importantly, the water will draw out of the tissues of the neuron. So out of the neuron, all the fluid will come out, and which will cause an apoptosis. So in this closed system, it's the Joule-Thomson effect. So the gas will expand when it has nowhere more to go, and it will drop that temperature. What's quite incredible about cryo, which is a physics issue, it's very different than radiofrequency or heat. What we are doing is touching the nerve. If we cool to a temperature of minus 20, which is common in many parts of Canada, you will get a frostbite. You will get a temporary conduction block, which will reverse. If you go up to minus 100, you will get secondary Wallerian degeneration or axonotmesis. That means the neuron will denervate. However, the axonal sheet and all the supporting structures, all the soft tissues, the blood vessels, they're all still there. We do not want a neurotmesis. So if you are treating a cancer or a tumor, you're going to do cryoablation. So you must tell your hospital and colleagues, we are not ablating anything. We are not destroying tissue. We are just causing the nerve to unravel. Because if you do that, you cause tissue destruction, which we do not want. You would also cause damage to blood vessel. So when you treat a tumor, you want to kill off the blood vessel. We know cryo, because the heat sink will not. So this is how we do the median nerve above the elbow. You see the pulsing blood vessel. This probe, it's sharp, but not that sharp. So it'd be very hard for us to pierce that blood vessel. We are going to find the trunk right next to the blood vessel, and we're going to stimulate that median trunk. So the whole hand will go like this, and probably pronate as well. And we will cause immediate interstitial freezing. We will create our ice ball, and we will denervation. For patients with lots of sensation, they will get cramping. We only ever do nerve trunks after doing a block because many stroke patients, or say an adult with CP, they don't have a lot of sensation discrimination. So you can take out their whole sensory nerve and they don't know a difference. But in a newer stroke patient or other CPs that are high functioning, they will immediately tell you their whole hand goes numb and they hate it. So we have to do selective motor blocks. So for a painful clenched hand, this is a miracle almost for their pain. And sometimes we will do above and below the elbow 3 lesions. If you do not completely destroy a sensory nerve, there will be pain. So here's an example of the rectus femoris muscle. So you can see we are stimulating with our probe because we're touching the branch going into the quadriceps. And there's 2 branches into the rectus, one on each side of the tendon. We immediately get Wallerian degeneration and fasciculation, telling us we've reached our target. So what happens under the microscope is we're not killing off everything. The green is the neuron tissue. So what we are going to do is we're going to destroy by apoptosis the green. This is a rat, so it will grow back quicker. You lose your green, and over the period of 8 weeks, that green starts growing back. So you get length-dependent reinnervation, so 1 millimeter per day, inch per month. Meaning in a long nerve, you may have a 1-year denervation. In a short one, it might be a few months. And this is another histology slide showing before and after losing your neural tissue, but the nerve is still there. It's not destroyed. In our textbook, we really didn't know how to teach this. In France, they were doing all of their blocks. The people who were experts, blind, no sound, which scared me because you couldn't see your target. It's lots of blood vessels, and it took a really long time. I'm an ultrasound expert for spasticity injections, so I asked Dr. Vincent to teach me to do nerve blocks. Though there was lots of literature in anesthesia, but nothing looking at selective motor. So we had to create our own textbook with all of our own blocks. And it was actually Dr. Vincent, when we started doing our own blocks, he suggested cryo. And I thought he was absolutely stark raving crazy to start freezing motor branches. But he said, no, my machine was built in 1980 in Oxford, and it's a very old machine, and it says motor stem. You can do motor. We do a lot of mixed motor branch and pain. So it had only been described in one case report in the 1990s of an operator nerve. So when we do cryo, we set up. We want to do very low stimulation rates. 0.8 milliamps is ideal, up to 1, because we always want to make sure we're on the motor branch and not on the just stimulating like with toxin anywhere in the neural tissue. For me, we want to increase range of motion, not just reduce spasticity. So the modified Tardieu scale is what we use. So in the modified Tardieu scale, you get a fast catch, and then you can range it as much as possible. And we were always taught with toxin, it's between the fast catch and the maximum, and that's it. But with nerve blocks, we know that's not true. So if you go into our textbook, we started with the pecs first. And then we realized we could probably do the lats as well, because they are important in some patients. It's a very easy muscle to target. You lie them on their side or on their back if they can't turn on their side. And you are going to find that thoracodorsal nerve. It is huge. It's very easy to see. And you're going to stimulate that nerve. Now, if you look at the bottom right-hand corner, there's actually a little white line going through. That's an intramuscular branch target that you can stimulate as well. So when we do cryoneurolysis, we're just going to go right into that target and freeze it with the serratus anterior underneath. Now, we were getting so good at this, and patients' range was getting so much better, and they wanted more. We realized we could do more. I was always taught to do the subscapularis from that posterior approach underneath the shoulder blade, which is so hard to get into. I think half the doctors doing it are just injecting air or the covering trapezius muscles. They can't see it. So now that we can do a block and get the arm up, we have a beautiful window to the axilla. So this this paper was just accepted for publication and should be out soon. And this is our new approach. So this is I worked with the Department of Radiology that if we can get the arm to about here, we can now see the axilla contents very, very well. So you can see the blue is latissimus dorsi, underneath it is the teres major, and underneath that subscap. So I can hit all 3 with 1 needle. It's quite an efficient process. So you could do nerve blocks, phenol, toxin, whatever you like with this approach. You put the needle in and you see the arm stimming in the subscap, and then teres major and lats. Now, one caveat is in very, very contracted muscles that are tight, you might not see any stim at first. And that's because the muscle is in such a compaction, it's not going to stim. So what you need to do is do one stim attempt, freeze where you know where the nerve is, and then suddenly the patient will start stimming as you relax. So this is an exact example of that. The patient's able to stim their subscapularis on the second attempt. I did a teaching clinic in Copenhagen in Denmark recently, and this was a woman who she had had an epidural bleed many years ago, and she also fell and broke her shoulder. She was getting botulinum toxin, and they said, but that's all the range you're going to get because, you also broke your shoulder, so you have capsulitis. But when we did the PEC, we saw she did relax, so I could now get into her axilla. We also did the elbow and fingers. She's another patient that's non-functioning, but she will be much more relaxed and open. So to explain how to do that, when I lifted up her shoulder after doing our PEC, you could see that crusted, awful skin underneath. So everyone says to me, Paul, you can't do the axilla, you're exaggerating. Oh no, she had severe tone, but we were relaxing the PEC, I was able to get into that thing. She was so embarrassed when she saw this photo, and I said, don't worry, it's just dried skin. So this was the very first patient we did. This is Dr. Rajiv Ribai, my colleague. His mom is from Mumbai. We did this nerve block, our first attempt at ultrasound-guided musculocutaneous nerve. And Rajiv was showing the fast catch and slow. We do catch and release, but when you do it with a block, the fast catch disappears. So what the lidocaine block tells you is your range is much better. He goes right to his end range, but he still seemed to have a contracture. So we did his nerve block, and this is the target. So we're going to attach the brachialis branch, which is down here. Biceps is up here, but we know from the French literature and the surgeons that this is the spot of the brachialis innervation point. So we have two choices. If we can get a nice stim, we will do the brachialis branch. Sometimes you just don't get that and you just go intramuscular. We want to stay away from the bottom of the blood vessel where the median of the radial nerve stays. So we can do intramuscular or the branch. So this gentleman was that first nerve block we did. Didn't propose that we do. So I studied it for 6 months and it seemed possible. And you can see the motion opened up completely. But he actually didn't even have that contracture. That was just too much spasticity. So we beat him. And now I'm saying, oh, can you move the arm? And he's like, oh, yeah, he's not used to moving his arm. So rather than his toxin wearing off every 3 months like it did, he's actually getting stronger at 6 months. And at the beginning, I would have put some toxin in brachioradialis and his interossei. We, of course, have replaced that all. So this is him 2 years after the procedure, still nice and loose, doing well. He can use that arm. He can carry things, carry his grandchildren, he can mow the lawn. We do the biceps as well. So this would be an example of a child with CP. So he has a congenital contracture of his bone. So we'll never get him fully out. But when we do a nerve block, we see we can get further length. Botulinum toxin generally tends to denervate and atrophy muscles. We find with cryo, the muscle gets bigger. So if we look at how small and tiny his muscle is on the right, look how big and beautiful. So when we do cryo, the muscle immediately pops up and the length gets bigger. So the patient can seemingly generate more force. So this is what the biceps looks like. So we're doing a lesion to biceps just coming off the vessel. And often what we'll see is just the top part of the bicep. One head is fasciculating. So we will then look to see here he's fasciculating only on the top of the screen, meaning we need to find another intramuscular nerve target. Now we're getting the lower head stimulating. So if we don't find another stimulation point, it means we've been successful and we only need to do one lesion. If not, we do two. Often we think the patient has spasticity in their brachioradialis, but they don't. So we see the muscle catch and release, but after we do the biceps or brachialis, it goes full. In other patients, you really see that muscle pull. So we are going to do the belly of the brachioradialis above the elbow. Now, if I do that heart-shaped radial nerve, they'll get wrist drop. So that's the nerve before it goes off to the brachioradialis. So I'm going to go look for one of those white lines above the muscle, stimulate, get the elbow to go like this, and then I can freeze at that level, avoiding the radial nerve, which also has a sensory branch.
This is the approach. Dr. Bossano, can you explain what you're doing?
So I'm going to do a cryoneurolysis to the motor branch for the brachioradialis, coming from the radial nerve.
She's doing that very nicely there. And so when we started doing this, Dr. Vincent had this very old machine from Oxford that you had to use replacement parts because there are no other brands in Canada. We realized we should start combining nerves. So this was brachialis and brachioradialis. His machine, you could just sterilize and reuse, so it was fine. Now, as an aside, for any of you who work with stroke patients, I wrote this paper with Dr. Alessandro Pacelli from Italy, and this is how we decide how to treat patients with novel hemiplegia after stroke. Obviously, you live in a part of the world that has the highest incidence of cardiovascular disease, so very fitting for you. And I can't go into this algorithm, but it's how we decide how to treat versus spasticity, capsulitis, and complex regional pain syndrome. And I'm very happy because the best literature in the world comes from Kalita in Uttar Pradesh, I believe. And I always use their literature on CRPS, complex regional pain syndrome after stroke. This is how we do the suprascapular nerve. There's many approaches. My colleague Nimish Mittal does it very differently with radiofrequency, but stroke is different. It's not an osteoarthritic problem always. So we know it supplies about 70% of the shoulder. We are not worried about weakening the infraspinatus. We've never had that as a problem. They don't have a lot of movement, so we're going to target that with up to 3 nerves. So this would be the classic post-stroke patient. He's on my rehabilitation ward. He's actually getting worse. The occupational therapist said, he's getting more pain, he's getting stiff, and he's getting tighter. And he's actually starting to get clonus. So during his rehabilitation in that 12-week period post-stroke, he is getting worse. So we're going to do suprascapular pain. We're going to do his pecs and shoulder, but we're also starting to do intramuscular branches, which was new. So he has good finger flexion, but he's like this. So we are going to do intramuscular branches to pronator teres, FCR, and if he has palmaris longus, and if needed, FCU. So by treating his pain in his shoulder, he immediately gains range of motion, and his clonus is going away, and he's moving. So we are going to send him back to therapy the next morning with incredibly more function and no recovery time.
Now, ready? Here we go.
Another severe shoulder pain after stroke, and you can see his pec muscle is so retracted here.
So you see this?
And we're going to treat the pecs. And we're going to treat his biceps because it's tight and retracted. He's a bit in that supinated position more than pronated.
Ow.
Yeah.
Okay. That looks like a great shape. Okay, perfect.
So I think we did suprascapular as well.
We see the biceps.
And you can just see the biceps, which was so tight on the left. On the right, it disappears. So this is how we do our shoulders. So this is a patient who has, reducible spasticity that we're going to do a nerve block on, and it's much, much looser. My colleague had tried botulinum talk, and he said, she would like to have more function. Can you do this? And this is her 1 month after cryo, and then 3 months. Now, she actually fell and broke her shoulder after for unrelated issue, but her range of motion was very good. She just came back 3 years later, and she was feeling tight again, so we repeated it, but she never went back to her baseline. Now, we really like the forearm muscles. It's fascinating. So this is the arrangement of muscles in the forearm. You have pronator teres, flexor carpi radialis. If you have a palmaris longus, it will sit to the side. If not, the flexor digitorum superficialis will sit below it. You can see the ulnar nerve actually passing below that, and then the FDP under there as well. So we can do selective motor branches for each one, because people who have a lot of sensation, we don't want to take out their median trunk. What we found, which is really fascinating, is most muscles, and I learned this from the hand surgeons, have multiple areas of innervation. So from the median nerve, we have a lower innervation point to the pronator teres, and then we have one above the tendon. So you can see us doing there. I'm now going to push my needle right through into the FCR, and I can get a stimulation of the FCR And on the right side of the screen, palmaris longus. If we don't do palmaris longus, it's very tendinous. We don't get good wrist extension. Then we can also slide right into FDS. We can also slide right into FDP if needed. Some of my dystonic patients need FDP, but in general, we find that FDS is the most important muscle to treat because you can open the fingers and then use the intrinsics and the FDP to close the
Eyes down
hand.
to the front.
Yeah, thanks.
And down. I'm gonna get out of the way, up to the top, to the side, over the top.
So this
go
is one of
further.
my children with
Oh my
cerebral
gosh,
palsy
and down.
who's had multiple
And up to the
surgeries,
side this
multiple
way.
treatments, multiple
And
rounds
all
of
the way up to the
toxin,
side.
and
And
just
just
still
swing
stiff.
it back and forth.
So in
Far as
CP,
you
you've
go back.
never had full range of motion, yet we can dramatically
Wow,
improve range
okay.
of motion
And
and
straighten it
function
out.
in many of
And
these
bring it back in.
people.
And straighten it out. This is crazy. Okay, here we go. Whoa! Oh my gosh. That's crazy.
So in her, I didn't
Look
need
at
to do the axilla. It was
that.
all
Holy
pec.
cow! Any movement?
So another example that we have now done about 25 to 30 patients where we do the cryo and we see such improvement in range of motion that we finally see that pec tendon. So we do the pectoral tendon after either at a later date or the same date if they travel from far away, and we get good improvement. Because you need to do the cryo first to get rid of the spasticity to lengthen the muscle as much as possible and expose the tendon. People say, why don't you do the tendon first? Because many people don't need the tendon, and often we can't see the tendon because of the tone is so much. I started a pediatric clinic recently with the help of my peds, because in my clinic, I can't give sedation on my own. We'll use nitrous oxide, propofol, virtual reality.
I had a brain injury on December 7th, 2020. I like to do soccer and I like to do gymnastics. After my brain injury, I had like a huge, this big of a scar.
Way overhead.
This was one of our first kids.
And the other side.
And this is an example where we
And
can
then
engage
right up to the side
function.
of this arm. Good. And
So
down,
this was a
and
child
like
who
this.
was very dystonic. She would not use her hand for
Straighten your
any
arm.
tasks because it was hard to
Bring it back
expose
in.
the hand.
Can you bring your wrist up
I
and down?
really want her to get a biceps lengthening, but
Gotta move
the
it and
family's
open your
just
fingers.
not sure. I think it's a minor procedure and they should do it.
Come straight on, Mattis.
But 1
Lift
year
up to the
later,
sky.
things were great, and I decided to
Right up
add
to the
in the
sky.
axillary group.
And down. And lift up again. Up to the sky. Wow. And out to the side. Over the top.
And you can see
Go
there's
like this,
still
up
some
and
shortening
down.
of that biceps.
Good. And straighten the arm out. Good. Open the hand. You open your fingers. Open and close.
And that's the
Good.
dystonia in the
Let
hand.
me see this. Well,
And again, we don't take power away. We find almost every patient says they're stronger after treatment because they relax their muscles to use them. All of those muscles of the upper extremity we have outlined in our textbook, and the intramuscular branches are in the QR codes. So we see how we can just do selectively do the FDS. And here is an example of just stimulating the FDS branch. Now, this was a man who had a stroke at the age of 15. He has a dystonic arm and a dystonic foot. So for him, we actually treated his FCR, palmaris longus, pronator teres, but also his FDP was a problem. They were getting stuck. So his dystonia was FDP. So by relaxing the FDP, he could use FDS.
straight it out. All the way.
Now, this was a woman that we just did quite recently, a couple months ago. I actually knew her through the community. She had a stroke at 19, and she really hides her spasticity. She has a good job. She just doesn't use her arm for typing or work, and she just doesn't let anyone see that arm. So for her, her shoulder was okay, but biceps brachioradialis were a big problem, and a lot of stiffness in those fingers. So it just fought her function. So we did her brachioradialis and biceps, which was the biggest problem. And then we did her FCR, palmaris longus, FDS. And that just freed up everything. And pronator teres. So I was really shocked when she sent me this video the next day that she was able to throw and catch a ball so well. And, you know, people say to me, well, we'll take away her power, but she's been that claw hand for so long. But by opening it up, she's now able to use scissors, which she, of course, has not done since her stroke. A few days later, you know, are we going to make her weak by taking out her wrist flexors? Nope, she's able to use them. And she was able to jog, but we actually did the leg as well. We're not going to talk about the leg because it's too much to talk about. But by doing the gastric soleus, it gave her tibial progression and length, so it could work. And here she's doing more and more fine motor dexterity. You can still see that spastic movement in the fingers, but it's better. Now, we did this at the end of May, and she came back the other day, and she told me that she held her nieces and nephews for the first time. She was afraid to hold babies in the past, that she would drop them. And I think even for someone like this, even becoming a parent was too scary because she was worried she didn't have the arm function. And that was her biggest reward, is that she can feed herself an ice cream. Just going to wrap up with a few more cases here. So here's ulnar nerve. So this is a man who has a spastic toe claw, so his toes claw, and his hand claws. And it's an unusual dystonia because it's a bit changeable. I'll see him kind of spontaneously open hand and then it gets stuck. So we did several nerve blocks, and it turned out it was really the interossei that were the tightest and the lumbricals. And I had done lots and lots of talks in there, but it didn't help. So we did an ulnar nerve below the elbow. Now he does go numb, and I'm going to try to figure out if I can find a target in the hand instead. But for him, he is thrilled because as soon as every 9 months I have to do him, because when the interossei go back, it gets stiff again. So you can see how tight he is. So by relaxing the interossei, we knock out those muscles in the dystonia. And many of our patients just have an ulnar deviation. So we will do just FCU alone, and we will leave the ulnar nerve below that muscle. So just to finish up, I'm sure you have many, many patients in your community. 9% of nursing homes in the West have claw hands of some degree. So this man is clawed, lower motor neuron.
Okay.
So for him, I just do median and ulnar trunks, which will allow me to open hand and take away the pain. On the left hand, I also did biceps brachialis just to open and
So you can
clean.
see there's some maceration in the skin that we've opened up. And then these.
So for me, we have a study going on the contracted hand. This is a man with MS with severe contracture in his hand. And we would have done, in this case, the ulnar nerve below the elbow for this function, and then just the FDS for those fingers.
When?
And this is the classic claw hand that we see. Very well looked after man in a nursing facility.
Pause it and then
We do median and ulnar nerve, and you can actually see the skin breakdown and maceration when we open there. You can't cut their nails because they're in so much pain. So this is a motor sensory blockade. It's incredibly compassionate because the hand heals and you can get a brace in there. So for me, this is one of my favorite treatments. Now, because we're running up to the end of time, we did do a study that looks at the safety. People always ask me about safety. Of course, this is not new. It's used by pain doctors. So we looked at 277 nerves of 113 patients under study. And what we found is 96.75% had no side effects. And almost all of the side effects were in sensory nerves, and it was almost always in the whole tibial trunk. And what we found was that most people, they would have pain for a little bit of time. But we now know, since we did the study, the treatment for pain is just repeat the procedure. It is partially destroyed nerve. It's causing pain. If they have numbness, it could persist from anywhere from 1 to 3 to 6 months, but it was a small number. And so now when we do a tibial trunk, we make absolutely sure there's no sensory disturbance. And then we just do each motor branch in the leg. In the upper extremity, very few side effects. Now, there's too much data to go through here, and I just want to tell you, we are publishing a lot of data, and basically what we found, this is the safety study, I'm just going to go through. We looked in the upper extremity, a 1-year follow-up of our patients, 58 patients in the upper extremity with severe spasticity. And what we found is at the end of a year, we still had improvements in modified Ashworth scale and improvements in the shoulder by about 20 degrees in abduction, external rotation, flexion, which is quite a big change, and then add an elbow. So we took the worst possible patients and still made a gain. And you can see the trend for range of motion improving on the left side of your screen, and the other two get better here. So So I'm just going to wrap up because there's just way too much to talk about. I share a lot of my cases for learning on Twitter because that's where I've met my international community. And if you're interested or showing your hospitals, we have 2 documentaries that we made. If you take a picture of this, one is very emotional and lots of talking. The other one is much more succinct for people with shorter attention spans. So I'm going to stop and open it up for questions.
Hello. Thank you very much, Professor Paul. It was a really great presentation, and really it was eye-opening for all of physiatrists, which we are working in the spasticity management. I have one question. As compared to the radio frequency ablation, if you talk about the radio frequency ablation and cryoneurolysis, in the conventional cryoneurolysis, conventional radio frequency ablation, the effect start usually 1 or 2 days. In the pulse radio frequency ablation, usually the therapeutic effect usually start in the 4 to 6 weeks. What does actually in the case of cryoneurolysis, the effect start immediately, or it takes some time to start for the therapeutic effect?
It's instant. So Andrea Truscott, so we have a new association called the International Society of Ultrasound Guided Cryoneurolysis. And most of the doctors there are anesthesia, and they all do, of course, radio frequency as well. And what they do both, and they also do cold. The advantages here that they will say is, one, you don't destroy tissue. So that's the big thing. And I know pulsed radio frequency doesn't, but they would also never do 20 lesions on one person, like all over the body. So with cryo, it is absolutely immediate. You get a conduction block the second you do it. So when you come to my training program, you're doing the procedure. You actually have to get a Canadian license. So one person's doing the procedure and one person's holding the arm, and they'll be like, oh, like you're literally holding the arm and it drops, or you're lifting the arm and it externally rotates. So within 15 seconds of the cryo, you get a conduction block and the effect takes place. So we see an instant effect, and then it gets better. And then over the coming days, you get more Wallerian degeneration. But then what also happens is you start stretching out all the other stiff muscles you didn't treat. So we see an instantaneous effect. And for the pain is gone immediately if it's going to work. If it's not gone immediately, you haven't done your ablation. Your neurolysis. So it's very fast. Now, I'm not a radio frequency expert. I don't have that set up. And for me, the big issue here is access to technology is the hardest thing in the world. So the machine we used was so old from Oxford, we didn't have a replacement in Canada. We only have the ablation machines for tumor. So this machine is from America, the iovera, because there's a question about it. It is a machine that we use, and it's a handheld with nitrous. So I don't need to have any Canadian or American. I don't know what your standards are. We don't have to have an HVAC evacuation room with nursing or recess because there's no gas. It's just a bike cartridge or a whipped cream. So it's very small. So I can use it in any setting. So that's the biggest advantage for me is I can go up to the intensive care unit. I can go to the ward. I can go to the nursing home. I can even go to their house and do the treatment if needed. So in Spain and Portugal, there's some people doing some radio frequency or pulse radio frequency for spasticity. If it works, fantastic. Like, I'm happy with whatever you do. I mean, I think we need to treat better. This is so much more effective. Nerve-targeted procedure, neurectomy, is so much more logical than something that lasts 3 months that doesn't increase range of motion. So I hope that answered your question, but it's a very different physics. And the last thing about that is Andrea Truscott will tell you that if you denature meat with a radio frequency or heat, put it in the microwave, you will destroy that meat and you can never use it again. If you take a meat and put it in the freezer, you can freeze it for 6 months, thaw it, and eat it if you're not vegetarian. And it's perfect. So cold doesn't damage, heat can damage.
If you talk in the perspective of spasticity management, how long this effect of the cryoneurolysis lasts? For how many months or years? Or do we need any repeated cryoneurolytic lesioning?
Yeah, so that's a great question. So what we're finding is it really depends on the underlying lesion. So the woman at the end who was throwing the ball, I don't think I'll ever treat her again because she's regaining motion so fast. She's stretching, she's hypermobile. She's going to get full length. So if I ever treat her, it won't be for the muscles I treated. It will be, I did biceps and brachialis and maybe I'll do brachialis. When those other ones grow back, I'll do another muscle group. So many people we add. In patients who have a dystonia, a true dystonic movement, as soon as the nerve grows back, the dystonia will come back. So that patient, I will tell them, you have 6 months. So you have 6 months of really good effect. It'll wear off at 9, and we'll do it again. But it's way more powerful than I find toxin to knock it out. And then patients who don't have a lot of active movement, they're just stiff. I find at about a year and a half, because they stop doing therapy, they tighten up again because of lack of therapy. And because they tighten up again, I'll repeat them about 1 year to 18 months. But some of them have come back at 3 to 4 years, said, you know what, it's finally getting tight. And it's usually something else has happened. They've had a health issue, they've got tight. So what I'm telling most of my patients is you have about a year, and then we'll decide if we need to retreat you.
We have, so Paul, we have some questions.
Sure.
What is
Can I ask one? Yeah, can I ask one? Yeah, Dr. Winston, I want to ask you a question. Essentially, we do neurolysis with phenol, which is basically, say, for example, the tibial nerve or the median nerve in the same way. Why don't we get the same kind of results with phenol neurolysis that we get with cryoneurolysis?
It's a great question. So, Shang Li, it's interesting. Phenol is not on label in almost any country for the treatment of spasticity. And I think it's because it's so cheap, nobody wants to study it. It's that simple. Like, it costs nothing. And what I think has happened is when you do phenol, you destroy the tissue. So we did a lot of reading on this. You destroy the tissue where you are. So whatever you touch, it kills. It's a noxious stimuli. So you probably get some tissue destruction and some fibrosis around that area, and it will probably just destroy the area. With cryo, because it's so cold, it literally destroys that area, and then you get a whole axonal denervation down the whole area, and then it has to go back. So I think you're getting a much larger area of destruction. That said, you can get beautiful results with phenol as well. So, I'm certainly not against phenol. The issue is when I speak to surgeons who, Marianne Keenan, who's my mentor from Philadelphia, she's an orthopedic surgeon, retired. She did a lot of the early phenol work in America. And she said, I'd go in and operate after, and there was so much scar tissue from what I did that I realized by doing it repeatedly, I damaged them. And with cryo, you don't damage anything. So with pain, you will do it forever, just like radiofrequency, you'll keep repeating it. So I don't know the answer to why phenol is not as good. There was a beautiful presentation, ISPM, from a team from India who showed very nice results. I just don't know. I mean, you guys could tell me, how often are you able to repeat phenol to get good results? I will tell you with cryo, for a few people I've done 3 or 4 times over 5 years, they get the identical result every time.
I think a whole lot of phenol literature is from the pre-ultrasound days, and I don't think there's too much from the ultrasound days, which is the modern era. I think if we redo it in the ultrasound era with precise localization and small amount of toxin, I don't think you'll get a whole lot of tissue destruction that you would otherwise get with just motor point stimulation or maybe with a landmark guided procedure. It's actually worth looking at.
Can you please do that? Because you know what the Americans are going to do? In America, they got a brand name for alcohol for cardiac. So the price went from 26 American to 1,000. And now in Texas, they're doing a trial on a new phenol. So I think they will take something that is $20 and make it 1,000. So please beat the Americans. We don't need them to ruin everything again. There was one question about cost, I think, there. So the cost will be the nature of your equipment. So the machine that I'm using is called the iovera, and it's a single-use smart tip. So it sells for $400 American. So that's one patient, 400 US dollars. I have done an analysis. My hospital is funding me. Canada is a social system, not like America. And they're agreeing to fund me now 32 patients a month. And my government just looked and said the average cost of botulinum toxin per patient that I've treated over their lifetime was 12,500 Canadian dollars. So about 9 or 10,000 American. In America, that cost would be about 25,000 American because it's very expensive there. And the cost of my treatment is 400 American. So they said for 200 patients, so far, before and after treatment, I've saved $2 million for 200 patients. That's per year. It's huge. In some of my colleagues in Europe are using the Metrum CryoFlex, which is a Polish machine. That is a sterilizable machine. They also have a single use for about 400 or 500 euros. So if you're using a reusable machine, you have two sets of costs. The cleaning the machine is minimal. However, if your hospital requires you to do an anesthesia room with proper renting the operating theater with a respiratory therapist and a nurse, you have the manpower, person power cost. So you'd have to weigh apart the 400 US dollars versus the cost of running a intervention suite. So the Department of Radiology in Vancouver just got this equipment and they said this was a no-brainer. By paying $400 for pain, we're saving like 2,000 to dollars on other costs.
Yeah. We have another questions. Just can you share your book name, Paul?
Sure. So
which is useful for the
is,
identifying the motor points of various muscles.
Yeah, I'm just gonna, what I'll do is I'll just share my screen again. If you, I hope that code will work. Use the European code to get the discount. And buy the book and share it. That's fine with me. I don't get that much money from I don't get that much money from each book. I get like €8. So selling it is not my interest. And we're going to be making a new copy eventually of the book to do more intramuscular branches. This is going to freeze up on me. I will get there. I have a YouTube channel and you can see it through my Twitter page with lots of the targets and nerves on there, and that will show you. Oh, sorry, not the end of the talk. Oh my gosh, this is embarrassing. It's slow because of it. How much does botulinum toxin cost in India? For 100 units or equivalent?
For 100 units, it's 25,000 approximately. For 100 units.
How much?
25,000.
And what is that in, say, US dollars or euros?
It's 83, 84 rupees.
Yeah, about I think $400 US.
$400 for one vial.
Yeah.
Yeah, so it's incredibly
100
expensive.
units.
Wow. So it's interesting because when I teach in Italy, it's only 100 euros. They have a cheaper brand there, a cheaper market. So this is the textbook here.
Yes.
Yeah, and I just want to say, several of you asked a good question. Like, I'm not here to say my way is the best way. We are researching. And if the book has a full chapter, 2 chapters on phenol, and if you were to use this book and get better results with phenol, I'd be so happy. I'd be like, wow, your patient did well. If you could send them for surgical neurectomy, if you could try radiofrequency ablation, we are just saying that targeting the nerve is better than targeting the neuromuscular junction. It just lasts longer. The other advantage is this is completely natural. This is a drug-free process, you know.
Yeah, sure. Yeah, it can be
I
a
live
good
in an
topic.
area of many indigenous people, for First Nations, the local, you know, they are very scared of a lot of drugs because the British, you know, used chemical germ warfare to eradicate them. They gave them smallpox and disease to destroy their culture. And here we're going to give them some ice. It's a much, you know, a much more palatable event.
Yeah, it is a good book.
Okay, are there any more questions?
Yeah. Where to purchase the book? Last question here.
So that's, if you scan the QR code, that's the website. But if you also Google it, it will tell you.
Okay.
Try to get your hospital or someone to buy it too. That's what I suggest, that the clinic gets
Yeah,
it.
that
So
would be the good option.
it's 149 euros. Don't buy
Yeah.
it from Amazon. It's too expensive.
Okay. It's better to keep your workshops in India in upcoming month or year. Then we can learn the good things.
Okay, well, we
Okay,
can talk about it. I have a lot of travel the next while, but that would be wonderful to do. Because what you need to do when I do workshops is, what I ask you to do is pick like 7 or 8 patients, send me a video of the patient, and we'll agree. And then you either block them first, or we block them together one day, and then we do the cryo later the day or the next day.
Because usually get with lot of neglected patient with the clinching face and this near to contracture of biceps, brachyradialis. These
My
patients
ask
are
of
very
all of
common.
you,
Yeah.
what I ask of all of you is, the next time you see that clenched fist, do a block of their median and ulnar nerve. Takes 2 minutes. Very simple to do. No harm, and see if the hand
Yeah, yeah.
opens. Because even with those clenched fists, even if you can block them and put a cloth underneath, often it's just stiff muscle, and you can do that. And then I do a digital block of their fingers with a bit of light, and I can often break that scar tissue. So just by doing a block, you can do it. And I haven't done ulnar and median nerve. I don't know what the work of is. You would know more than me. But frequency would work well. All right, I'll let you all go. Thank you for the talk. If there's any questions,
Thank you, Paul.
you can send them to you and for me, or reach out on Twitter or LinkedIn. That's how people get in contact.
Sure. Yeah. Thank you very much, Paul, for accepting
your
our
time.
invitation and giving your precious time for webinar.
Okay. Take care.
Yeah. Thank you.